So thank you for everyone for joining us today. For those who don't know, I'm Rachel Denholm. I'm a researcher in applied health data sciences at the University of Bristol, and I was one of the co-applicants for the HDR UK Better Care partnership, which this project is from. And so I thought I'd just give a quick background to the IPACS project before Christos and Alison give their talk. And so this was back in 2020, and a HDR UK program initiative was started, which was around leveraging the Bristol, North Somerset and South Gloucestershire system-wide data set for research. And it was a collaboration between the University of Bristol, Bath and Exeter and the Bristol, North Somerset and South Gloucestershire Integrated Care Board. And there was one package of work that was around developing infrastructure to make this data available for research, but also IPACS is one of the work packages from that. And it was unique in the sense that it was embedded within the trust. It was led across Bath, Exeter and the ICB, and it was truly integrated within the commissioning model with the researcher in the ICB. And through that work, the team delivered something that we all strive to do, which is the benefit for NHS and the academic research as well. And so on that note, I'm going to pass over to Christos and Alison to talk about the IPACS model some more. So thank you very much again for joining us. Thank you to Alison and Christos.
Thanks, Rachel. I'm going to start. My name is Christos Vassilakis. I'm professor at the University of Bath School of Management, and I'm the director of the Center for Healthcare Innovation Improvement at the same university. So we have Alison Harper with us, who's from University of Exeter, and who will do the heavy lifting with this presentation, actually, as it happened with the model, to be honest, with the project itself. So we're presenting the IPACS model. IPACS stands for Improving the Flow of Patients Between Acute, Community and Social Care. And that was a project, as Rachel told you, that it was funded as part of HDR UK's commitment to the Southwest. Alison, next slide. There are not many slides for me, but just give a little bit of introduction. So a number of people were involved directly with this project. I was Rich Wood from the ICB, and we kind of hired Paul Forte, who was a long-time collaborator of mine from my days in London. He worked out of the ICB for the purpose of this project, and it was me and Zara Onendumlu from University of Bath. Zara is on maternity leave at the moment, that's why she's not joining on this call. And we had obviously Martin, Pete, and Alison from the University of Exeter. And I think Martin ends of the call, or at least I saw his name flashing just a few minutes ago. Now, in terms of the timeline of the modeling, we started the project idea. It was Richard Woods, that is, and I think we discussed it for the first time at the very, very end of 2019, so probably just before the Christmas break, and then we committed to paper at the very first month of 2020, January 2020, and the project started in April 2020. Now, there's no prizes for remembering what happened between us putting this project into paper and the project actually starting. So as you can imagine, the pandemic, the lockdowns and the associated disruption played a big role in this project, both in terms of not allowing us to do certain things that we wanted, but at the same time, influencing directly or indirectly the type of scenarios and the questions we asked the model later on, as Alison will explain. And next and final slide for me, please. And again, the project ended in March 2023, so this is not an active project as we speak, although we're hoping for its continuing impact, especially with the collaborating ICB. Now, before Alison explains the specifics of this project, I thought it would be good to just give you a brief explanation of data analysis versus computer simulation. Now, this particular project and the talk is more about computer simulation. On one hand, we have data analysis, which is something that I believe you're familiar with, ranging from simple techniques that we have in descriptive analytics. I don't know, you think of means and standard deviations and histograms and interquartile range and the like. Moving to more advanced, when we do correlation and regression analysis, and moving to even more advanced techniques like machine learning nowadays. So this is all the data analysis part. Now, this particular project was a lot about computer simulation, and by computer simulation, um, which you might have heard computer simulation in its various guises, some like system dynamics or Monte Carlo simulation or discrete event simulation. It can be used to construct, or how we actually use computer simulation is first we typically construct a baseline model that captures a care process or care process as is. In other words, we try to get as closely as to reality as possible with assumptions and simplifications. And then the main aim of this kind of activity is to then produce a number of variations on the baseline model and run computer experiments, what we call simulation experiments, within the context of what-if scenarios. So we can ask questions like what might happen to patients waiting in A&E to be admitted to hospital if we had more beds on our wards, or what will happen to waiting times if we had more or fewer patients being referred to the service. So this is how we use simulation, and it's quite different to the way we use data analytics, business analytics than most people are used to. So that's why I thought it would be good to clarify this. And Alison, now you can take over and tell us all the exciting detail about the IPACS program.
Okay. Thank you, Christos. So the purpose of the IPACS project was to develop a simulation model to support planning and resourcing of complex care discharge pathways. And as Christos mentioned, that started during COVID, where reducing delayed discharges became a big priority to get people out of hospital. And we wanted the simulation to be able to conduct what-if analysis to support that planning and resourcing. So the project was participative in that all parts of the model were co-developed with our project partners, or in fact where it was led within BNSSG. That included the conceptual model, input, design and validation, outputs and output reporting, scenario design and usability, etc. And that was to a large extent, that was facilitated by our project manager, Paul Forte, who really, his main role was to facilitate between the needs and priorities and perspectives of the different organisations that we were working with, and on the one hand, and then on the other hand, the capabilities of the simulation model, because we anticipated that there might be difficulties in conducting a simulation study across these organisational interfaces, which also might explain why there had been little work done in this area before. So we wanted the model to be used both for short-term and for long-term planning. We were focusing on delayed discharges, and this data is subsequent to the end of the project. And it's not reported in the same way now, but I've had a look at the most recent data that was provided in this, and it hasn't really changed all that much. So effectively what it's saying is that around 14% of patients are discharged after their discharge readiness date. The majority of those between 1 and 3 days, but a significant proportion of patients are still waiting up to 2 weeks and even on to 3 weeks or more, with an average delay of 6 days. So if we assume 100,000 beds available in England and around 11,000 patients per day are fit for discharge, then this equates to around 560,000 acute bed days lost. So this is still obviously a priority area. We initially conceived of the pathway as a sort of fairly simple linear process from acute discharge from acute care. A certain proportion of patients then require some ongoing community healthcare service, and then from there a certain proportion may require some ongoing social care. We needed to develop the simulation model that captured the key elements of the system, which crossed multiple interfaces. So we're looking there at an interface between acute care and community care, and also between National Health Service or healthcare funded services and local authority funded services. So for those who are not familiar with simulation, the idea is to develop a high level abstraction of a system, and then, or a model of the system, and then as you simulate it over time, it models the flow of individual patients through the system with a stochastic element. So in other words, it incorporates the randomness that we see in real life. So the model began at the point of I don't know if you can see my cursor. It began at the point of discharge readiness from hospital, and the majority of patients are discharged without any ongoing care needs, but a certain proportion of patients need some further care and are referred onto an appropriate pathway, pathway 1, 2, or 3. If there's capacity in the pathway, they're admitted to that pathway and discharged from hospital. And if they're not, then they're delayed in hospital. So those are patients with a delayed discharge. And then a certain proportion of those patients might require some ongoing social care services afterwards. Within BNSSG, there are 3 local authorities: Bristol, North Somerset and South Gloucestershire. So we spent a significant amount of time engaging with all 3 of those local authorities to try to map their pathways between acute and community, and particularly into social care, to try to find the pathway elements that were common to all of the social care processes. And it was quite difficult to do. They're quite complex and they were structurally all quite different. And this is a simplification of that, actually, because mostly the social care services in fact overlap with the pathways 1, 2 and 3, and also there's some direct admission into these services as well. But as it happened, we were actually never able to get hold of any social care data that we could use. We did get a fairly large data set, but there was so much missing data and missing values and duplicates and just sort of erroneous or not useful entries that we weren't actually able to clean that up into a data set that we could validate and make any use of. So from the beginning of the project, in the initial phases anyway, we decided to focus just on the NHS pathways, mainly working with the ICB, who were leading the project, and the community providers, Sirona. Luckily, both saw value in the model. So alongside Paul, our project manager, who was facilitating relations for us, that we were able to get a joint understanding of the processes and the data. But there were still significant challenges that in some cases took some time to iron out, such as misunderstandings about data definitions and different perspectives and priorities, etc. As a team, we worked with both the ICB and Sirona. But we wanted the team in the ICB who were running and using the model to take ownership over the data inputs and those collaboration efforts that were required to understand the data and the inputs into the model. We also worked with a subset of acute data, referrals in particular, the referrals directly into the pathways, to try and understand why the referrals into the different pathways were not necessarily translating into arrivals and into the community side, and whether that was to do with data definitions or whether it was to do with some structural aspect of the system that we had missed. There were 2 model modules that we were working with. One is a bed-based model and one is the visits-based model. So both accepted time-dependent stochastic arrivals and stochastic lengths of stay. But the main difference was that the visits-based model had an additional source of variability in that it allows for a varying number of visits per day per patient and assumes that the numbers of visits required will reduce over the duration of care. So although in reality visit needs don't always reduce in a kind of strictly linear fashion, which is how the model captured it, this approach can accommodate both patient level variability and also that gradual reduction which is typically observed in practice. Also, where higher acuity patients are discharged into community services, the impact of this is not just in terms of increased demand, but also in terms of the numbers of daily visit requirements. And we also wanted the model to reflect this. Unfortunately, we weren't able to get hold of visits data, and that was really because Sirona didn't collect visits data. They worked with an average number of visits per day, so we had to make some estimates around that. We had a kind of an idea of a minimum and a maximum number of visits and the mean number of visits, so we could still calculate a visit trajectory for each patient. But we were also able to make some changes to that if need be. If we knew, for example, that higher acuity patients were going to be accepted onto a P1 pathway that maybe required 4 visits per day with 2 staff members, that would equate to 8 visit capacity slots, for example. So we could still make some estimates around that. There were some other model assumptions that were required. We assumed that all patients referred into a pathway will enter the pathway, but in reality, some patients might enter a different pathway or they might not enter a pathway at all. The model assumed that if there's capacity in the pathway and there are patients queuing, they will enter the pathway. But again, in reality, patients might be delayed for a variety of reasons which aren't related to community capacity. The capacity in the model is static over the model runtime, but in reality, some flexing of capacity occurs. For example, spot purchasing of beds or reduced workforce can change the available capacity. And finally, the mean lengths of stay are also stable over model runtime. And in reality, actually, the lengths of stay vary for a number of reasons. They can be dependent on downstream social care capacity, for example, or families intervening in care, or a number of other reasons that we weren't able to capture in the model. We needed the model outputs to be meaningful for all of the organisations involved, and these were the set of 4 that we agreed upon. So the outputs are time dependent across the model runtime, so it can be visualised per day of the model runtime. To make the results accessible and comparable across scenarios, we provided a set of plots in an output report that displayed just the mean outputs, which you'll have a look at in a minute. But to support meaningful decision making, it was also crucial to present the full range of stochastic outputs, as the simulations inherently involve randomness. Their outputs are variable. So, for example, while the mean given a scenario, a mean output might suggest that 40 beds are required in a given service, but the actual requirement might be anywhere between, say, 30 and 50, and that should fall within the full range of simulation outputs. So it might not necessarily be the best idea to work with the mean. You might want to err on the side of caution, for example, and plan above the mean. So we looked at the number in service, that's the number of patients predicted to be in each discharge pathway, the numbers of patients awaiting service, so these are the patients delayed, the number of patients who are the numbers of days delayed in the acute sector, and that allowed the calculation of lost bed days by multiplying the number of days delayed by the numbers of patients delayed. And we also had costs, so we wanted to calculate the total system cost per day, which was the sum of the community cost and the acute delay cost multiplied by the number of patients delayed for a given amount of capacity. Unfortunately, we were never able to get hold of data on costs, so I'll show you this a little bit later, but we had to also make some estimates around that as well. And we were never able to really fully validate the costs that we used in the model. We assumed from the beginning that that there would be a U-shaped curve as we looked at increasing and decreasing community capacity, which you can see there on the x-axis, and the balance of the balance. If we balance the cost of that capacity with the cost of delayed discharges, that there might be a kind of cost optimal capacity that minimised both of those costs, which we did see here as sort of a minimum point. Given the uncertainty in costs, we did some sensitivity analysis of plus or minus 10%. So this would be the base case here, plus or minus 10% of community costs, and then plus or minus 10% in each case of acute costs. So that's all combination. So what that shows is that the community costs increase the total aggregate costs, but not the cost optimal capacity, which is that point that minimises the total system costs, whereas changes to acute costs have got more effect on total system costs at lower community capacity than at higher. And you see this exponential increase in system costs and variability when community care is operating under capacity. So at this point, the system is more sensitive to changes in costs, but also the costs are rapidly increasing at this point as well. The model was flexible enough to be able to model a range of scenarios. So we could look at, for example, what if we can reduce the length of stay in a given pathway, or change the number of the amount of capacity in a given pathway, or move patients from one pathway onto another pathway, or consider if demand changes, for example, if it goes up over winter, and if so, how much extra capacity might we need to accommodate that. It could also model short-term scenarios, such as if we're noticing lengths of stay are increasing, what do we need to do to try and bring that back? How many extra beds do we need to spot purchase? What happens if we send a proportion of patients from a well-resourced pathway into an overloaded pathway, and how many would we need to send, and do we need extra capacity to support that, for example. In BNSSG, the model was used in a variety of ways. So early in the pandemic, it was used for COVID planning, as Christos mentioned. We combined two forecasting models. One was developed by an analyst in BNSSG, which showed the effects of movement on ED, which was the opening up of lockdown, on ED presentations. And we also had an SEIR model from BNSSG. So we combined both of those to use as model inputs to be able to estimate the effects of demand on community services. And then we also used it to making some assumptions about a peak in demand due to the Omicron variant, which was, I think, in winter 21-22. It was used for winter planning in all years during the project. And then towards the end of the project, BNSSG had some management consultants examine in detail the appropriateness of their referrals into the different pathways. And their findings suggested that a large number of patients could have been referred onto lower acuity pathways. So BNSSG put together a set of realistic scenarios around this, estimating the effects of changing the split of patients across the different pathways on the resourcing and delays. It was also used for short-term planning. So, for example, where do we need to focus our efforts over the next 2-3 weeks or months or whatever. This is an example of a scenario table. So the model for short-term planning could output a maximum of 12 scenario combinations, which could be compared between each other. And it outputted that into using Markdown into a Word document. So each of the scenarios would include all combinations of inputs which were read off a Microsoft Excel file, which would include the baseline case, which is the basically the current situation, and then each of the variable parameters of capacity, length of stay, and arrivals could then have one other scenario, and then one of those could have a third scenario. So 2 by 2 by 3 is 12, total of 12 scenarios. So in this instance, we're looking at baseline capacity and unrestricted capacity, i.e. what kind of capacity might we need if we don't want any delays at all. We've got a baseline length of stay, we've got a target length of stay, and then we've got somewhere in between. And then for arrivals, we've got the baseline current arrivals, some sort of current arrival trajectory, and then a change in the split of how those arrivals are directed down the different pathways. So these would produce an output that would look something like this in the report. And remembering in BNSSG, we've got 3 different local authorities and 3 different pathways in each. So we would have a set of 9 outputs for each of these reports. So for this particular pathway, we've got on the top here the mean numbers of patients in the pathway, the mean number of patients in hospital waiting to be accepted onto a pathway, the mean numbers of days that patients are waiting, and then there would also be the final facet would be costs, but that isn't shown here. So what we're seeing here is you can see there's a flat line on the top here, which means that there are a couple of scenarios here, the red and green ones, which are kind of bottoming out or topping out, ceiling out, whatever. They're hitting their capacity. And the result of that is that the numbers of patients delayed in hospital are gradually increasing over the model runtime, which is around 5 months, and simultaneously the numbers of days that patients are waiting are delayed. So if we just go back and look at which scenarios they are, that's the red one is the baseline, the current situation, and then the green one is the current situation, but with some interim targets around length of stay. So it looks like reducing the lengths of stays are having some impact on the system, but maybe not enough impact. And it might be that some of these scenarios here just below the capacity might be the ones that need to be looked at in a little bit more detail. For short-term use, we had a go at setting the model up to automate its outputs with a routine report that could be produced, say, every 2-4 weeks. And the aim was to pull the data directly from the system, populate a spreadsheet of parameters, and then initialize and run the model for all pathways and localities and output the report using our Markdown in Word, which was what was wanted. So all of this could be done easily just by running one script. Unfortunately, we couldn't automate the community data inputs. These had to be manually updated in the spreadsheet, which significantly reduced the functionality of the automated reporting. So we were able to, in real time, we could automate the baseline arrival rates, and we could create some demand trajectories around that for the duration of the runtime. We could initialize the model with the current numbers of patients delayed in hospital and the current numbers of patients in service. And we could run the model with some standardized pre-agreed scenario analysis. But we needed to do that extra step to manually parameterize the model for the current lengths of stays in each of the pathways, and the visit requirements if we wanted to change that, for the current capacity, for changes to standard scenarios, if we wanted to make any changes to the proportions of patients entering the pathways or entering different localities, and also if we wanted to make any changes to costs. So that additional step kind of negated the value really in the automated report, and ultimately I think they just carried on doing just manually updating the input sheet. In terms of the data required for using the model, so we could get hold of, from the ICB, we could get hold of the numbers of patients in service per pathway and the current numbers of patients delayed, and these were used to initialize the model. We could get hold of the mean referrals per patient, and from that to create some predicted referrals for the model runtime. From the community providers, Sirona, we could get hold of the current available capacity per pathway. We could get some length of stay data, and this was emailed over as a kind of output report in PDF format, which provided some parameters. I think it provided the mean and the median, but for whatever reason, we were never able to get hold of patient level data so that we could calculate some estimated distributions around the lengths of stay in each of the pathways. We never got hold of visits data, as I mentioned, and this is the cost data that we use. So for P1 and for acute costs, we derived these from 2017-2018 NHS reference costs, so they're probably already out of date at the time that we were using them, but I think they stopped providing NHS reference costs around about then. For P3, the data came from BNSSG, but I'm not quite sure why they weren't able to provide the other cost data. I guess it just wasn't available. For P2, we got the data from the National Audit of Intermediate Care, and we got 2017-2018 data to try and match it up with the NHS reference costs. But really, we were never able to say how the costs were calculated and whether they were calculated in a comparable format to across there. So we were really sort of looking at the relative ratios between the costs for use in the model. We also had some mean referrals per pathway from acute care, and we were able to use that to validate the data from patient arrivals into the community providers to try to understand why there might be a discrepancy between the two. In terms of future work, ideally we would like to be able, or would have liked to have been able to model, to initialize the model with all of the data and also to automate it with all of the data points. It would be useful to be able to have variable capacity over model runtime, just to incorporate, for example, some planned increase in capacity at some point in the model runtime. Lengths of stay were a tricky one because lengths of stay were incredibly variable, but we had to make some assumptions that they stayed static across the model runtime. But in actual fact, they don't, and they can vary quite significantly. And they're dependent on a wide variety of reasons, including downstream capacity, but there are also behavioural elements as well. So when things are a bit overloaded, I assume some decisions can be made that can kind of reduce lengths of stay in the pathway. So probably the only way to capture that would be some kind of hybrid modelling, maybe having incorporating agent-based modelling, for example, that might be able to make some probabilistic changes to length of stay based on some of the other changes in the model. Oops, sorry, go back there. I've mentioned this one already. This as well was another a part of the model that we did have a go at focusing on. So effectively what was happening was that at some point in that delay period, when a patient's referred into a pathway and when they're accepted into a pathway, different things can happen. They might not enter the pathway, they might get better, they might get worse, they might go home, they might go into a private service or go home to their families or something like that. So we knew that at certain, in many instances, in fact, that the model was overestimating the numbers of patients delayed in the in hospital, and obviously the ICB was sort of taking that into account when they were interpreting the results. We could account for that to some degree by accounting for jockeying, either moving between different pathways and reneging, so not entering the pathway at all. But we needed to have some data to support that, and as far as I remember, we never had that data to support making that particular change. So we just ran with the assumptions we had. Obviously, ideally, we'd have visits data and cost data. And then finally, down the bottom there, just sort of some suggestions for where the model would go next would be for to integrate social care into the model as and when that data is available, maybe to integrate variable staff types. So we were looking at, for example, the P1 model. We assumed homogenous staff were providing those visits, but obviously that's not the case. We might want to look at variable patient types, and discrete event simulation can accommodate that, and different behaviours within the model associated with different patient types as well. So that could be got from primary care data. And we could also perhaps look at improving short-term demand predictions into each of the pathways by using information about current inpatients in a classification model based on known features about patients such as age, comorbidities, admission status, etc., and then use that to predict referrals into pathways. Okay, so I'm winding up. I hope I'm on time. The outputs of the model did provide an indication of the potential effects of local policies on patients accommodated, on the pathways, on queues in hospitals, on the length of waiting time and average cost. But perhaps more importantly, in BNSSG, it did support system-wide thinking and encourage collaborative working across services. For us, the challenges that we, to some degree or in some cases, weren't able to overcome was that not all of the data might be available. Not all of the data might be available, but it couldn't be automated, and also that data fields can be defined differently by different service providers. In particular, what we did find is that the challenges in implementing the model, these challenges might still exist, that working across services requires shared goals and incentives, and between and across decision makers and analysts. So importantly, analysts, because they've got the best understanding of the data and what it means in terms of driving the model to achieve that close cooperation and the joint priorities that are required for a modelling and simulation project. These are some of the papers that came out of the project. So the first one is a conference paper, which provides an overview of the project and the model. It provides a really kind of neat overview of the whole project. The second one there is our COVID modelling and the resultant service utilisation and costs associated with that. The third paper shows that that maybe the most cost-effective approach is not to aim for completely eliminating reduced discharges, not to completely eliminating delayed discharges, sorry. And in the last paper, that was also a conference paper which focused on the P1 model. Okay, so just there is the link to the GitHub repository. If anybody's interested in having a look at the model, it could be picked up and reused as is. But you might want to spend some time thinking about how it might benefit your own systems. And within the repository, we've got a significant amount of documentation as well that shows how to run the model and the kind of scope of the model as well, and some of the assumptions within it. But now might also be a good time to think about building on this existing work to try to accommodate some of the improvements discussed, given improvements in data collection, how the secure data environment might be able to support that, and also the ongoing interests in planning tools in this area. So I'm going to hand back to Christos and Rachel at this point.